Okay, we're going to go ahead and get started. Good morning. My name is Greg Smith. I'm Executive Director of the Florida Literacy Coalition, and it's my pleasure to welcome you to the Florida Health Literacy Summit. This event is the result of a multi-organizational collaboration to shine a light on health literacy and strategies for clear health communication. Today, we plan to share with you what we hope you'll find to be useful information, as well as have a dialogue about what we can collectively do to help empower our patients, students, and clients to access and understand relevant health information, especially those with low literacy, low health literacy, and limited English skills. Did you know that according to the National Center for Education Statistics, approximately 1 in 5 Floridians, that's 20% of our adult population, have below basic literacy skills. Good health outcomes are often dependent on clear, plain language communication. So we need to find effective ways to reduce the gap between the literacy demands of the health system and the health literacy skills of many Floridians. We believe this is truly fundamental to health equity. So thanks for being here and being part of the conversation this morning and this afternoon. With that, I'd like to recognize some of the organizations and individuals who've helped to make today possible. First and foremost, I'd like to give a big thanks to our presenting sponsor, Simply Healthcare, which has generously provided financial support to make this event a reality and has also been involved throughout the planning process. So Liz, Maria, Lynn, we certainly appreciate all of your participation. We also like to thank our event partners and planning committee members. All of these companies and organizations were represented on our committee, and these folks were truly key to the planning, promoting, and offering of this professional development opportunity. And indeed, several of our committee members are among today's presenters. And here's our committee members, so thank you very much. I'd also like to thank our team here at FLC. Heather, our Health and Family Literacy Coordinator, has done a great job taking the lead for our organization on organizing the event, assisted by Isabel and Giovanna, Susan. It's been a real team effort, so thank you very much. It's now my pleasure to introduce to you Christy Castaneda, who's the Director of Change Management for Simply Healthcare, to offer some welcoming remarks and to introduce our keynote speaker. So Christy.
Good morning, and thank you, Greg. I'm really happy to be here today and to join you in this summit. On behalf of Simply Healthcare, we are here to not only show our support for this very important and amazing work, but to also collaborate in breaking down health literacy barriers. At Simply, we know that health literacy is very vital to our members and all of our communities. We also know that health literacy barriers impact health outcomes, reduce adherence to treatment, and increases medical costs. Our goal is to educate the community and make sure that they make the best healthcare decisions for themselves and their families. To do this, we rely on dedicated and determined community partners like yourself, Greg, and the Florida Literacy Coalition. The coalition has a myriad of services that advocate for quality adult and family literacy services across the state. This work helps ensure that people can effectively comprehend and communicate information, allowing them to be more engaged, informed, happy, and most importantly, healthy. We are hopeful that our support can help convene educators and health professionals in exploring strategies to tackle health literacy issues across all of Florida. I want to thank the Florida Literacy Coalition for your enduring commitment and your work in literacy, training, program development, and advocacy. It is through these crucial partnerships like these that together we can all continue to make a positive impact in the lives of so many Floridians. And now I would like to introduce our keynote speaker, Dr. Rima Rudd. Dr. Rudd is a pioneer of health literacy whose work and research has advanced health literacy in the past decades. Dr. Rudd, now an associate of the Department of Health and Social Behavior, has been a member of the faculty in the Harvard T.H. Chan School of Public Health for 35 years. Her research studies and teachings have focused on reducing health disparities through attention to equitable access to health information, services, and care. As one of the founders and leaders in health literacy studies, Dr. Rudd drafted the first national call to action related to health literacy. She has served on the original Institute of Medicine Health Literacy Committee, written multiple health literacy research white papers and policy reports. She has also helped broaden the notion of health literacy by introducing the importance of analyzing skills and health system characteristics that reduce barriers to information and services. Dr. Rudd currently serves as advisor for several national and nonprofit organizations across the US, Europe, Japan, New Zealand, and Australia, and has received various awards for her contributions. Wow, those are truly some extraordinary credentials and experience. I'm so excited and humbled for this opportunity to learn more from Dr. Rudd, and I hope everyone here is also. And now I have the honor to introduce to you Dr. Rima Rudd. Dr. Rudd, take it away.
Wonderful. Good morning. I'm really absolutely delighted to be here. And I'm just going to set up the context for where I'm talking from in just 1 second as I get my slides appropriately set up for you. So sorry about the delay. Well, I should have practiced this a little bit better. Forgive me.
Hit play from start there. I think you'll be set.
Excuse me?
You hit play from start here in the corner, in the left-hand corner. Under home. There you go.
Yep. Okay. Oh, wonderful. Thank you so much. I really do apologize for that. And so finally, here I am setting the context for where I'm speaking from. Leaves are changing. There are more leaves on the ground now than in the trees, and soon we'll be celebrating naked trees and the coming of winter. But right now it's pumpkin time in New England. I'm really thrilled about this conference because you have at today's meeting a number of partners and coalitions already that set the stage for taking efficacious action in support of health literacy. People from public health, from adult education, from various social services, as well as healthcare, libraries, community-based organizations. This is a very strong coming together of very important voices in the correction that we need as a country for better communication and for improved health literacy. Of course, there's the common ground of literacy. And we all come together understanding that literacy is fluid. It can be expanded or contracted. We see this with aging population, for example. For people who are no longer working, their literacy skills shrink a bit because they're no longer using their full skill set on an everyday basis. We also see adults coming into adult learning centers and invigorating their skills, furthering their skills. So literacy is not a characteristic of an individual. Literacy is a skill set that can be expanded and contracted. Literacy is also an interaction. It is not a characteristic. So it's an interaction between me, the speaker, and you, the listener. And if I'm not clear, you can't comprehend. And so the burden of responsibility in this case is really on my shoulders, not yours, to understand. And the fact that literacy takes place in a context, a social and physical context. And so if my background noise was not muted, if there was loud music, if there were talking behind me, you could not listen to anything that I was saying. And that impacts your comprehension skills. but it's not your comprehensive skills that are a task here. It's the context that's very important. The other thing about literacy that we all agree on is that it includes a number of factors: reading and writing, listening and speaking, calculating, working with new technology, problem solving. Literacy is also, I think we all agree, a common good. It's long been known that literacy has an effect on personal growth and creativity, on one's ability to change one's economic and social status, on making a contribution to society, on civic engagement. And actually, there's a lot of history behind it. I only took out one or two notes. We've long recognized the power of literacy. Just a reminder, in the 1830s, most Southern states made it illegal to teach people in slavery how to read. Why? Partly because they understood the power of literacy. Horace Mann in 1827, Massachusetts, very influential for law changes. Massachusetts, the first state in the Union to establish a free public school open to all. John Dewey, who made the statement that public education is really the foundation for a free and democratic society. And it's an obligation to make sure that we are attentive to that important issue ourselves. We know, and again, some mention has already been made, that health literacy emerged from education field. It was the findings from the International Adult Literacy Survey starting in 1992 that really opened everyone's eyes to the actual reality of literacy in industrialized nations. We long took it for granted that public education would ensure solid literacy skills. And I think our nation and many other nations throughout the industrialized world were shocked in the 1990s to find that that wasn't the case. The research findings of the surveys of adult literacy skills in the 1990s and regularly thereafter brought attention to the lack of literacy skills in industrialized nations. The key question among health people at the time in 1993, 1994, when information was published, are there health consequences? And that really began the effort to research and to study literacy in the health context, what later became known as health literacy. So it's a relatively new area of research, and its origin is very much linked to the education findings of limited literacy skills in our society. The initial focus of health literacy, some of this is still going on, was looking at health literacy as an attribute or ability of an individual. And in so doing, in truth, there were very important findings in the health field. We understood and we had documented proof that people with limited literacy skills are less likely to know about their illness or disease or medicine. They're less likely to successfully manage a chronic disease like asthma or diabetes or heart disease. They're less likely to engage in preventive activities, getting the flu shot, for example. They're more likely to die at a young age. There's a substantial body of literature now that links the literacy skills of individuals to health outcomes. However, there was an error made early on as well. And that error, I use the same quote here, health literacy as an attribute or ability of an individual. It took a long while to hear the voices of our colleagues in literacy research and practice to understand that literacy is not an attribute or ability of an individual. That was an easy way of measuring it. We were unable at the beginning to improve patient skills. So what good did it teach us to say that people with limited literacy skills are less likely to manage their diabetes? And I do remember a well-known doc at the time saying that at the beginning, she had an attitude that, oh, I understand why you're not managing your diabetes properly. You have low literacy skills. And she said it took her a while to hold up a mirror and look in the mirror and say, perhaps you're not managing your diabetes well because I don't have good communication skills. And so the idea that literacy is an interaction came a little bit later to those of us in the health field. We needed to figure out and to look at the skills of the communicator, the complexity of the tests and the tasks that we ask people to undertake, and the circumstances under which people were making decisions and taking action. There are now well over 4,000 peer-reviewed articles in medical and nursing literature that shows that information, medical information, health information is poorly written, poorly constructed, and more often than not, written at a level well above the average reading skills of US high school adults. So something is wrong on the other end of the scale. So we moved, it's an evolving concept, this notion of health literacy. We moved from looking at health literacy as an individual characteristic to looking at health literacy as an interaction, and started focusing on the match between people's skills and the texts that they were given, and making sure that we are focusing on making a change, improving texts. And now more and more we're looking at health literacy as an outcome of social factors. We're looking at measures of accessibility. We're looking at how to change the system, to look at systemic barriers, and therefore, perhaps, we're hoping, reduce the unfortunate burden that is placed on people who are seeking healthcare. They are not responsible for the comprehension. We are responsible for good comprehension. So we have to pay attention to the literacy skills of the reader as well as the communication skills of the writer. And we have to pay attention to environmental factors that influence access, concentration, comprehension, inclusion, and action. And these barriers need to be removed. Health literacy is very much tied to health equity. We talk about access to information, people's ability to access information. Well, we have to focus on access to accessible information. We have unfortunately focused too long on available information, making information available. But if available information is not comprehensible, is not readable, is not accessible, it's not there for people. And so we have to shift our focus there. We have to eliminate the secret language of professionalism, the jargon of our various trades. We have to make sure that numbers and displays of data are presented in such a way that they inform, not confuse the public. We have to look at access to care and services and make sure that institutional barriers are removed. And this is really what I hope to focus on today. So in considering systemic issues, we need to look at the physical as well as the social environment of our organizations, of our agencies, of our hospitals, our healthcare centers, our dental offices and medical offices as well. We have to identify the facilitating factors. We have to identify the barriers. And the first step is not to strengthen the facilitating factors, but it's to remove the barriers. You don't press people towards an exit door unless you're really convinced that that exit door is opened. So we need to remove barriers before we add incentives to change. Our current process, we know that health inequities are based on literacy skills. There's documented evidence for that. We have insight into the literacy and numeracy challenges that exist. We know the skills of the public. It's well documented. At first in 1992, through the NALS, the National Assessment of Adult Literacy. In the 1990s, throughout the industrialized world. In 2005, another assessment that was done in the United States, and more assessments that were done internationally regularly. And in 2005 and 2007 and 2011 and 2017 and 2019, we have very strong evidence, and we must become familiar with that evidence, because we have to understand what the skills of the public are and correct our unfounded assumptions. We have to improve health professional communication skills. This is very important. For the most part, those of us who are in the health-related fields, in the social service fields, are well educated, well prepared to present and understand information. But at times we forget that we might be speaking a foreign language. The language that we learned in our graduate schools, the language that we learned in our work, the secret language that perhaps the general public doesn't understand. We need to improve our skills. We need to improve the quality of health information. And there are mechanisms available to us. We have to learn how to use them for improving health communication. And we need to pay attention to the systemic issues of the environmental barriers. And so there are many action steps that we can take together. The focus of health literacy is really to build trust through dignified exchange. Dignified exchange, you're not talking down to people by using plain language. You're talking with people when you're using the same language, when you're using common words and commonly understood terms. We have to identify literacy-related barriers in our work, in our workplace, in the procedures that we use. We have to increase access to actionable and accessible information and support social justice through this. So our needed focus, again, to make information accessible, not just available. And this is true not just in the written word. We're not just talking about assessing common brochures or how-to pamphlets, but in all of our writings, in how we speak to people, the language that we use when we're speaking with people, the kinds of postings that we do, the kinds of displays. It's very disheartening, throughout the COVID pandemic to watch presenters first talk about percentages of people and then start talking about numbers in decimal points. And then talk about fractions. You're expecting too much of people. This is an absurdity. We wouldn't do that to our students. And even in graduate school, we are consistent in our approaches, and we need to be more disciplined in how we present data. We need to be more disciplined in how we prepare information for the public. Too many people are cutting corners. They're not pilot testing messages and displays and text beforehand to be able to make corrections when they find out from the audience what is clear and what is not clear. So there are processes that have long been documented as important processes for communication that many of us have forgotten to use. Many of us are not putting into play, but we know about it. We need to build knowledge, and this is the talk. There's a lot of literature now about the democratization of information, making it easily accessible, but also making it engaging people in discovery, engaging people in finding out their experiences, their perceptions, and incorporating those experiences into our talk and into our work. We need, again, to rebuild trust, which has clearly been eroded for a number of reasons, many of them unfortunately political. But again, this is a never-ending task. And as discouraged as some of us might be, we need to continue to engage in that process. And having a dignified exchange with people, speaking the same language with people, is one way to solidify and build trust. Partnerships with all of us from the different perspectives that we're now representing in today's meeting, adult education, social service organizations, health institutions, libraries, and others, is a way of working together for coherent messages, working together for a similarity of approaches, working together for dignified exchanges with people, with the goal of improving access to care and supporting health inequities. Spheres of analysis and action are very much there. There are responsibilities that the education sector holds. When early on, when adult education programs were partnering with health sector efforts, we did find, as was mentioned earlier, that people with lower literacy skills do have reduced ability to manage a chronic disease, for example. Well, the health sector was stymied because they didn't have the skills, we didn't have the skills to improve people's health literacy. And so it was very important that we turn to the education sector and say, we need to support you. We need to help improve skills. We need to learn what you're doing so that we can do things better. So that effort to come together of health and education was extremely important. We needed the insight from literacy experts to finally see that from the health perspective, our understanding of health literacy was stymied because we didn't understand the interaction at the very beginning. So that partnership for action is extraordinarily important. And then we in the health and social service realm have strong responsibility, partnering with those of you in education for sure, but enhancing our own education. And I see that there are several people in the audience and online who are actively engaged in doing that right now. We need to improve the quality of health texts. And again, whether it's spoken, whether it's online, whether it's on paper, whether it's posted or displayed, we need to reinstitute rigor in the preparation and development and assessment of our information. That means pilot testing. That means developing it with a great deal of care and information learned from health literacy studies. We need to reduce our expectations as far as tasks are concerned, what we expect people to do. We have very high expectations of folks who are diagnosed with a disease. And now we need to look at those expectations. What is it that we want and expect people to do to help themselves? How difficult are those tasks? What literacy skills are needed in order for people to engage in those tasks or accomplish those tasks? And how can we ease the burden? How can we make it easier for people? That's an exercise that we very much need to engage in. A very trivial example might be just looking at questionnaires, for example. Everyone, almost everyone, has to fill out some sort of questionnaire when they come into a health center or a social service center, some background information, sometimes health information. Questionnaires, for the most part, are designed and written in such a way to help the person who's collecting the data. Those people who then take those handwritten questionnaires and sit at a desk with a computer and are entering that data. We need to make sure that those questionnaires are easy to fill out, that there's enough space to write in, that the questions are logical from their perspective, not necessarily from the perspective of the data collector. So we need to look at the tasks we expect people to engage in and simplify them. So it's reducing our expectations and to make tasks easier. And we have to look at the environment, the very important environment. Is it welcoming? Is it easy to come in? Do you feel comfortable asking questions? Do you feel comfortable navigating? Can you find your way about? Can you come back? You go to a social service agency and then they are giving you a very important and very valuable referral to another group. Can we find those people? Can we easily access those services? We need to look at the characteristics of a variety of services and institutions within our health and social service system and make sure that it's accessible and friendly to all. So what I'm moving towards is an expanded notion of health literacy, not a characteristic of people, not an ability of individuals, but a concept that includes the skills of the lay public as well as the professionals. That includes attention to the texts that we use. And here I use a literacy related understanding of what texts are. They're either written or spoken or posted or displayed. They include all those levels of communication. We have to make sure that our texts are in line with the skills of the audience for whom it's intended, the general audience. We have to look at tasks and we have to look at context. So in this expanded notion of health literacy, I'm claiming that health literacy can be found at that intersection of all four of these: skills, text, tasks, and context. And when we talk about skills, we're not just talking about skills of individuals, we're talking about the communication skills of professionals as well. When we're talking about text, we're talking about things that are through talk, our communication and talk, the vocabulary used, the syntax used, the tone used, but in writing and postings as well, whether it be in books or online. When we talk about tasks, we're talking about the activities to be undertaken. The activities to be undertaken, for example, once you're able to make your way through an RX form, we look at the label of the medicine. And now the activity to be undertaken is to take it, not just to understand what's written, but to be able to take it in a clear and active way. Just again, a somewhat trivial example. I was once challenged in a large talk at a university focused on preparation for pharmacy practice. That I was told by the dean that we pharmacists understand, we know what's involved in clear communication. And she put up an RX form and it says, take one pill by mouth 4 times a day. She said, could it be clearer than that? And so I took up the challenge and said, yes, it could be. I just came from another location to give a talk here. And so I was already prepared in the morning. I set my alarm. I had my needed medicine at my bedside in the morning with a glass of water. I took my first pill when I woke up. I showered and took care of hair issues and others in the bathroom. And after I brushed my teeth, I took my second pill. I went down to breakfast. And with my orange juice, I took my third pill. And then just before I left the hotel room with my case in hand, I took my 4th pill. Wasn't I a good girl? And the dean was able to say, oh no, we pharmacists forgot about titration. We didn't mean 4 pills all at once. We meant throughout the day. So there's good intention. There was never bad intention there. There's good intention, but we really need to examine our materials with rigor. We need to examine our directions with rigor. And we need, again, to pilot test and understand that we expect people to do something, to take action, and we need to be assured that we're there helping and making sure that that action is easy to take, simple to take, clear to take. And we have to look at our context. And here is when we're looking at systems level facilitators and barriers. If people do not feel comfortable accessing, if there are barriers to entry, if people are ill-treated, poorly treated, if they're spoken to in a degrading format or in a language that they don't understand, they're not going to be able to access care and services. And so we do have to look at our policies in an institution. We have to look at our procedures, the clarity, our explanations, how we treat people, how we explain things to people, the systems level facilitators and barriers, the policies, the regulations, and other work that's involved. Again, just one simple example. We talk about materials, questionnaires. Well, a hospital or health center, in all truth, they don't develop their own materials. They buy those materials. There's a contractor that they use. Well, perhaps there's power in the contract. Perhaps that we need to make sure that the policies of the hospital are such that they make it a part of the contract to say, give me proof that you've pilot tested this material. Give me proof that this material is accessible and has been well tested by available tools. That should be part of the contract. It doesn't need to be the responsibility of the hospital after the fact, after they've bought the materials that they're going to distribute to their patients. So when we talk about skills, certainly know the audience. It's our responsibility to become familiar with literacy, strengths, and deficits. The population has been assessed as far as reading, writing, numeracy, oral exchange, use of technology, problem-solving, navigation. It's all available online and at the Education Statistics Center in the United States through the United Nations, readily available. We know that the average literacy, numeracy, technology, problem-solving skills of US adults are limited. A majority of US adults have difficulty using commonly available materials with accuracy and consistency. Signs in use, materials in use, forms, newspapers, bus schedules, taking a 10% discount in the vegetable market. These are difficult tasks for a majority of adults in the United States. Yes, we rely on the education system to make corrections, to build stronger skills. Yes, we rely on adult education to draw people in and to engage people in wonderful ways to improve their skills. But we in the health fields can't wait. We can't wait 10 years for people to improve their skills and therefore manage their asthma better. We need action now, and we can take action by making things easier for people, by understanding where the skill set is and working to that skill set. I just want to remind you that the mean literacy score in the United States was 13th out of 24 industrialized nations. We're not doing a good job of making those changes. Who has limited literacy and skills? This is true, by the way, across the industrialized world. Older adults compared to working age adults. And there's a big debate in the literature that you must be familiar with. Is it the decline of cognitive skills with age? Perhaps. Is it the fact that people are no longer actively engaged in work and using their literacy skills on a daily basis? Perhaps. There are two arguments at play here, but the fact is that older adults do measure with lower literacy and math skills than do working age adults. Immigrants compared to native born adults. That makes sense. As far as language and the predominant language that is used for most materials. This is true in all industrialized nations. Adults who have not completed high school or obtained a GED in this country. Adults who are members of minority or marginalized populations. This is true in every industrialized nation. Even in Japan, which has amongst the highest literacy skills tested in industrialized nations. Those people who are members of minority populations, it may go back many years, but perhaps 400 years ago have a history of coming from another country or being an indigenous, a member of an indigenous population. So marginalized populations in all industrialized nations test with poor literacy skills. This tells you something about the power of social factors, the power of being under-resourced. Adults living in poverty with no income from savings or dividends or retirement funds have lower literacy skills than other adults. Adults with health-related restrictions that limited school or work activities have lower literacy skills, and adults living in under-resourced areas, like rural areas, like inner city areas, without active resource to find schooling, libraries, and other adult education programs, for example. So partnership and support is a responsibility to support education, to support adult education, to develop referral practices, 2 adult education programs, 2 education programs, to develop partnerships for professional development. We in the health field have a lot to learn from adult education specialists and literacy specialists. And I just testify this as far as my own career. So my early partnership in the 1990s with the adult education sector has really benefited me a great deal. I learned a great deal, and it changed my research, and it changed my approach, and it changed my practices, the insights that I garnered from the adult education field. Partnerships for professional development, share information, insights, and skills are incredibly important. Skills of professionals, we have to learn more about literacy issues. We have to offer training in all of our organizations about the use of available resources and tools, the use of not just readability assessments, but something like the CDC index, which helps us look at a piece of material and develop a real sense of whether this material is adequately and appropriately developed in order to communicate important information. There are scores that you can get that tell you, there are correctors that you can use that help you improve the text, and you can turn the assessment tool on its head and use it as a way to develop materials, as a guidance for developed materials. Many tools are available, they're freely available, they are online, and they're very insightful. We have to be able to assess materials that we use and apply rigor to the information exchange. Make sure that we assess all the materials that we're developing as well. So in order to engage in respectful dialogue, we have to do this. We have to take responsibility for the interaction. We have to attend to numeracy displays. This is relatively new in the health literacy field, by the way. It was a long time coming before we paid attention to the fact that data displays are not being appropriately used to communicate with the public. We are not using numbers with ease and making sure that they're accessible to people. So as far as our texts are concerned, we have to attend to texts. We have to do the math for people, not assume that they can do it, develop materials with rigor, focus attention on vocabulary, displays, concepts, organization. Again, rigor. We do not allow anyone, any company, to develop a pill to cure something without careful testing. We cannot be audacious and develop a message without understanding whether that message is comprehensible. We have to apply scientific rigor to everything that we do. Yes, it takes additional time. Yes, it very often is more costly. But we don't let drug companies get away with that argument. We insist on scientific rigor. The word, the number is very important. Communication is extraordinarily important. Trust building is incredibly important. And we have to approach that with due rigor. Sorry, slow down here for an example. I give an example of the available tools, but I'm sure many of you are familiar with it. The SMOG, amongst all the readability tools, it's probably the strongest because it considers sentence length as well as word length. Keep in mind, it's not appropriate for languages other than English, because English is a somewhat unique language in that we have a lot of silent letters in our words. It teaches us how to use shorter sentences so people don't get lost in our clauses and our long lists, and make sure that our message comes across easily. So yes, it's worthwhile doing. It's not the best assessment. The SAM as a tool, again, available online, developed by the Dokes and Root as a way of really looking comprehensively at a text and understanding all aspects of it, not just the words, not just the sentence length, but also the format, also the underlying cultural assumptions that might be embedded in the text. The CDC Clear Communication Index I mentioned, the PIMOS iCurse, which is a tool that's focused on looking at a document such as lists, charts, and graphs. It has an unfortunate, cumbersome name based on Peter Mosenthal and Erwin Kirsch, who developed it. but it's a useful tool to see whether a display is adequate or too cumbersome for people to use. So with tasks, I had mentioned earlier, we have to examine our expectations. We have to ease the burden for people undertaking a health-related task. For context, we look at the atmosphere. We need to check navigation ease. We have to examine the policies and regulations within an institution, the training that's offered to the professionals and staff who are working within that institution. We have to assess the resources that are being made available to people. Look at the normative behaviors and norms. We have to argue that an 11-minute visit with a doctor is insufficient. We can't take that for granted. We have to argue that for people with disabilities, and this was a very important thing in the newspapers this last week, for people with disabilities who are treated differently in medical offices and in social service offices, we need to look at time and can't just take the limited time for granted. We have to analyze the behavior of people when we're undergoing a procedure. Are things being explained? Are they being explained adequately? Are they being explained in a warm and friendly way that make us feel part of an effort to improve our health and not simply the object or the subject of a procedure? So we have to analyze the social and physical environment and plan for change. Again, the importance of identifying barriers and removing them first before we strengthen the facilitating factors. We don't want to push people against a closed and locked door. We need to make sure that we identify as many barriers as possible and remove them. So again, strengthening institutional practice comes about through partnering with others, changing contracts with suppliers, articulating expectations for professional practice in a clearer and better way. Examine your own workplace, the context within which you work. What makes it hard or easy for you to work with clients? How can it be made easier? Identifying the goals that you have and reducing barriers for your own clients. So examining one's own workplace is a very interesting activity to engage in from the perspective of your clients in order to increase access and reduce barriers. So again, health literacy is not just looking at the written word. It's not just looking at materials that are there for people, but it's looking at a wide variety of literacy-related barriers and how we can remove them. So again, that expanded concept of health literacy is fourfold. And these are 4 areas where we can take action. Many of us take action in one area. It's always better if we can take action in more than one, in at least 2 areas of change. It's ideal if an organization or institution can take action in all 4 areas. So in support of equity, respectful dialogue, welcomed engagement, democratization of knowledge. That means not just available information, but accessible information, and use of tools for decision-making and action. I have an assessment tool that is now widely used in this country and in others. It's an assessment tool for looking at your organization, policy and practices. It's freely available online. But you're going to hear a lot more today about opportunities for action, examples of action successfully taken by others. And so there's a very exciting adventure for the rest of this day. So I don't know, I hope that I've left sufficient time for some questions or comments. And I turn the meeting over to you, Greg, and I'll stop sharing my screen.
Okay, well, thank you very much, Dr. Rudd. And yes, let's open it up for questions. And Heather, have you been monitoring the chat, or do we have any questions?
I have not seen any questions as of yet, but please go ahead and add those in the chat.
Or if you prefer to unmute yourself, that's fine too, and maybe just raise your hand. So if you prefer to just ask your questions directly.
I have a question. Do you think it's feasible to introduce health literacy classes in medical schools and like pre-professional schools?
Absolutely. And I must say that we've been trying to do that for 20 years to some success. I think Dr. Coleman is actually a part of this conference. I saw his name earlier, and he might be able to speak to that. Am I correct that he's here with us? There you are. Hello, Cliff.
Hi, can you hear me okay?
Yes.
Yes.
Well, what a pleasure to get to hear you start my morning out here in the Pacific Northwest. Well, it's still dark out. Just to, I don't want to take time from Dr. Rudd's comments, but there's a lot of work going on in medical education currently, and much more that needs to be done. So I certainly encourage you to all to get involved in that and look at what's available currently. And we all have lots of work we can do in that area.
Right. And social work school, nursing programs, not just medical schools, pharmacy schools, and in agencies for continuing education credits. So yes, there are wonderful examples available of people who have already, and institutions have already begun this, but unfortunately it's still very few, but the examples again are freely available for us to be able to apply and use. So thank you. I would say, yes, it's more than feasible. It's definitely a strong possibility and is already in action.
Thank you.
So in the chat, Terry Johnson shared with us that FSU does discuss health literacy with their medical students. I believe UF does as well. So we are seeing some of that in our Florida institutions. I see another question for you, Dr. Rudd. Do you have thoughts on how to address health literacy issues that you have identified with individuals who have who have comorbid communication disorders, such as persons with aphasia secondary to a stroke?
That's been difficult. I just want to point out that, for example, professionals in mental health have only recently begun to do work in relation to health literacy, because a lot of the health literacy work early on was really focused on the general public, and there has not been enough attention paid to improving health literacy in more discrete areas of need. So no, that's an area of work that I think is still wide open and needs attention. We've been slow in that area. It doesn't mean it's not important, by the way. It's not a level of importance. It was a matter of the difficulty of addressing these tasks.
Dr. Rudd, I know you did some work a number of years back with respect to, I think it was a study or some work in New York and in Boston and other places where health professionals partnered with adult educators and utilized students to provide feedback with regard to signage and materials and communication. Can you speak a little bit about to that in how the adult literacy students help to inform that process?
Oh, for sure. Actually, the little wave that I did for my own work about the assessment tool for looking at institutions and social service agencies, as well as hospitals and health, grew out of that partnership. So I conducted, for example, well over 100, personally, well over 100, and colleagues of mine developed many more, tours with adult education students. Adult education students were wonderful partners because, one, they were going back to adult education to improve their skills. So they were not uncomfortable saying, I don't understand that. That word makes no sense to me. And they were not embarrassed by saying that. And so we did walking tours in a number of hospitals in the Boston area. Then I expanded it to working with adult education centers and programs throughout New York City, which wonderful partnership there. And we would take a walk through, it was a set schedule that I had. We would take a walk through an institution to find our way, meeting in front at the main entrance, and then walking to, for example, the asthma center, never a patient floor, mind you, but a center that would give some service. And as we walked, the adult education student at the beginning was my informant, would say, well, I'm taking a left turn here because that sign points me in the direction, or I'm stopping. I don't know where in the world I am. I'm going to go back to the information desk and find out how to go. So we did those tours together, and that was the basis of the work that then became the assessment tool. Their insight was incredibly important and very powerful. So too was the insight of the adult education teachers, by the way. So doing that kind of tour with an adult education teacher, as we were walking down the street and we saw the sign for ambulatory entrance, the teacher stopped me and said, we know that ambulatory is an old-fashioned word. People don't talk about taking an after dinner they don't ambulate after dinner. They take a walk. She said, but I want to point out something else to you. My students in adult education will often look at a difficult long word like ambulatory and look at the first few letters and then make a guess. And they will say, that's where the ambulances go. And they are wrong, but that's a common mistake. So again, insight drawn from that partnership was just so important to me personally and to all of my work. So yes, that partnership was very powerful. As a result of that work, by the way, we developed a series of programs for adult education programs to introduce health topics into their work, and use health as an example to further the development of literacy and math skills. But we can talk about that another time.
Very good, thank you.
So Karen Strange shared that some pre-med students at FSU are volunteers in their live literacy program. And that's definitely something that we have seen in our work at FLC, that it can be so helpful to both the adult learners and the pre-med students. Have you heard about other types of partnerships like that that could be very useful for both sides of that partnership?
Yes. Queens Hospital, for example, not only did partnership with adult education programs in a two-way street with the hospital, so that people from adult education came into, the teachers of adult education came into medical school programs to talk about skill sets that people do and do not have. And medical school students came into the adult education centers, but there was also a link with libraries. There was also a partnership with libraries. And so when there was an effort, for example, at the beginning of flu season, the libraries were partners with the hospital for postings and signs and references. And the libraries ended up helping the hospital set up a library for patients and their families within the hospital, being able to look at useful and accessible information and material, not material that was meant for the medical staff, but material that was accessible to the families. So that was a tri-partnership that was very powerful: adult education, libraries, and hospitals, just as one example.
I know, Dr. Rudd, there's been a lot of focus on social determinants of health in recent years. I was just wondering your thoughts in terms of how health literacy factors into that.
Well, I think literacy is a social determinant of health, period. And literacy is socially determined, so it makes it very complex. Your literacy skills as an individual are very much dependent upon whether or not you had books in your home, but even broader than that, whether or not you had good programs within your community, whether or not you had access to a library within your community, what the quality of the public education system was within your community. So your literacy skills are socially determined by the resources that are available in your community. And in exchange, your literacy skills then offer a social determinant of your health and well-being. So it's a very complex issue, but literacy is definitely both socially determined and a social determinant of health. And I think that's becoming more and more widely acknowledged.
Very good. Any other questions, Heather? I'm not seeing any myself here, but.
I saw another comment from Richard. He said that students in the health-related professions at UCF are conducting and publishing health literacy-related research. So that's great to hear, beyond even a class, that we see students starting to do research and really immersing themselves in the field. That's great.
Yes, and I've borne witness to that in the School of Public Health, as well as in the allied, medical schools that are part of the Harvard system. Absolutely.
Looks like also in North Dakota, they're doing some work with medical students. Doesn't health literacy also differ with the part of the US that one lives in? Nancy wanted to ask.
Yes, it does. There have been a very interesting analysis, a state-by-state analysis of literacy as well as health literacy. So yes, it does vary, and it does vary by economics. And it does vary by access to services, which are very often politically determined. So yes, there are parts of the country, and I think that you can all probably name them logically, that have much lower literacy skills and health literacy skills than do other parts of the country. And I mean, that information is readily available, but as many of you would guess, they are poor, often southern states that have lower literacy. They're more often rural than they are urban.
Is there one or two resources, websites that you would recommend that really do a nice job with sharing health literacy related research and information?
Well, I really do like the CDC website on health literacy. And there are 2 programs that you can take. I think it's Literacy 101 or something, that it will take you through almost a course. It's all free, about health literacy and building your own skills. And then there's even a more sort of an upper level course that you can take online. That is very valuable, and it even has segments where you can look at math skills and building your own understanding of math challenges and how important math is into health in health contexts, and how to improve that. So I think that the CDC website is one that I turn to. Institute for Healthcare Advancement, IHA, also has a very strong website and access to courses and programs that are freely available, and that it offers a good website as well. Mine at Harvard was one of the first websites in health literacy, but because of circumstances on a personal level for me, it's woefully out of date, and I really need to bring it up to date. So I'm not listing mine as a top site at the moment. The Horowitz Health Literacy Center at the University of Maryland has an excellent website as well. So my listing would be probably CDC, IHA, and the Horowitz Health Center offer very, very insightful resources for people.
I was wondering, are there any lessons that came out of the pandemic? Certainly an event where communicating health information, across the country was crucially important. I don't know if there was any related research, but has anybody taken a look at sort of lessons learned through the pandemic?
Yes, I actually did a very early article with Cynthia Bauer, who had been at the CDC and is now the director at the Horowitz Health Center, about early lessons learned, but there have subsequently been several articles about that. One lessons learned is that the lack of consistency in the same message and message giving really proved terribly problematic and helped erode public trust. The presentation and vocabulary of data was very confusing to people, and again, helped erode public trust. So those kinds of lessons about how we're presenting data, what the consistency of a message is very problematic. There was a very just before the epidemic, in this country and the pandemic in general, there was a series of meetings at the National Academy of Sciences about communicating science. And we have recognized that we have faced tremendous difficulty over the decades in communicating science. We who can call ourselves scientists have not done a good job communicating with the public. And one example is some work that I was engaged in Fukushima, Japan, where it was very clear the scientists, this is after the triple disaster, the scientists were giving information to the policymakers. The policymakers may not have understood all of that information, but they certainly passed it on to the doctors and nurses. And the doctors and nurses were expected to pass on that information to the public. However, no one translated that information. So in truth, the doctors and nurses started saying that they did not understand the scientific information and data about, for example, radiation numbers, what those numbers actually meant. And they were tasked with communicating that to the public. Well, when a member of the community asks a public health nurse, can my child play in the playground today? And all the nurse has is a number. Well, the radiation level is X. The mother starts being very skeptical about turning to this nurse for help and assistance. So the communication of information on a scientific level in many realms is something that really needs to be attended to. That's a definite lesson that was shown again with the COVID. Sorry, I wasn't completely
No, that was, yeah.
coherent with that.
I'm wondering, since you've had such a long career in this field, what are some positive changes that you've kind of seen? Have we had some successes kind of along the way from, when you started this research to now?
Oh, yes, I do remain incredibly optimistic and in a sense buoyed by the passion that I see in the field. So again, the success in seeing the partnerships develop between literacy experts, education experts, adult education experts, and people in the health and social service field. I may say at times that they're slow in developing, but they're developing and they're there. And there are many throughout the country, many wonderful examples of very positive efforts and positive work being done in communities as a result of these partnerships. Again, I gave an example of libraries. There are many other parts of the country where I can use that same example of library work. But I'm a little stymied. I just can't draw something too quickly right now, but I do feel very optimistic. I feel that people are incredibly sincere. The recognition of the importance of literacy, that literacy is a social determinant, is something that is engaging more and more people and making them look in that mirror and paying attention to the fact that, my goodness, communication is very important. How do I improve my skills? How do I improve my presentation? How do I make sure that the person sitting opposite me feels valued, feels listened to, feels part of the exchange, that we're working together to solve a problem? That the person is not an object of some study. So I think that there has been a real culture shift over these last 20 years that we can celebrate. And there are definitely very strong, the literature gives rise to this. There are very strong examples of successful programs.
Yes, thank you. So Alba commented that many students commented to her organization that the CDC did a terrible job of communicating in plain language. The graphics and language they used were complicated and challenging. And we heard the same from some of our adult learners in Florida. So I guess that is a challenge, right, in communication, but also as information is developing, any ideas or suggestions on how we can kind of communicate in something that isn't clear, as COVID was, right? We didn't know all of the information. We didn't know about transmission. We didn't know as much about prevention in the beginning.
Well, unfortunately, a lot of the spokespeople from the CDC did not use the information that is available online at the CDC about what is good communication. And the CDC does a good job of explaining what is good communication. Clearly, it didn't do a good job of using that information. So part of the issue is us, all of us. Are we putting into play what we know? Are we applying what we ought to apply, or are we taking shortcuts? Are we reacting to the moment, or are we being disciplined? And I think that we really do need more and more to pay attention to what it is that we're doing and whether or not what we're doing is scientifically sound. So I think that that will move us forward if we are disciplined, if we move forward with rigor. And I've been using the word rigor a lot in all of my presentations and in my work, because I think we all know the good things to do. We all know things about good, strong communication. We all know about building trust. And sometimes in the heat of the moment, in the spur of the moment, as we're sitting down to do our work, somehow that knowledge is not being put into play. So it's being rigorous that I think is the most important thing that we need to do now.
Well, thank you, Dr. Rudd. Our time has come to an end, but I certainly appreciate all the great information that you provided and insightful commentary and for your leadership in this important field. You've really helped to set the stage for our day, and we appreciate that. I do want to just take a minute to do a little bit of an overview for the walkthrough on the day. So if you could bring that slide up, I appreciate that.
Oh, sorry. I have it on my screen. Am I still sharing the screen?
Yeah, if you can just share that last slide that you had up at the end there.
Yes.
So hopefully everybody's had an opportunity to look at the portal. We're hoping that that's pretty self-explanatory. We have 2 series of concurrent sessions, each with three sessions. The next one starts at 10:30. Then we'll break for lunch and then have a set of concurrent sessions after lunch. Now, all of the sessions will be recorded, and we'll also be sharing the PowerPoint presentations. And if the presenters provide some additional supporting documents, we'll be sharing that as well. So those will be available next week. And so we will break for lunch at 11:45 a.m. So that'll be your time. And then reconvene at 12:15 for the second set of sessions. And then for our closing session, we were going to do something a little bit different. We recognize that these virtual events, there are pros and cons to virtual events versus in-person events. And one of the trade-offs usually is that it's a little bit harder to have discussions and dialogue in the virtual events. So we wanted to have a closing session that really was focused on that. So we'll have some roundtable breakout sessions where we'll come together and for about a half hour, have small groups taking a look at sort of takeaways from the day, topics raised during the day that may be of interest to you to talk further about, some reflections on successes and potential challenges related to health literacy, potential partnerships, action steps, and so forth. So those will be facilitated sessions, and we do hope that you'll come back and join us after the last round of workshops for the closing session. So with that, unless there's anything that I forgot to mention, Heather, are we good?
So,
Okay.
I think we're
sounds
doing
good.
great. Thank you
Okay.
so much.
Well, thanks everyone. And so we look forward to seeing you at 10:30. Just go into the session of your choice and click on the button there. And just like you did for this one, you'll come right into the session. So see you in a little bit. Thanks.